Traumatic injuries to tooth. It is an emergency condition in which there is injury to tooth and supporting structures. Trauma to teeth may result either in injury of pulp with or without damage to crown or root, or in displacement of tooth from its socket. When the crown or root is fractured, pulp may recover and survive the injury, but it may sometimes undergo degeneration and ultimately pulp dies. When luxation of tooth occurs, the pulp may survive depending on the violence of blow and degree of dislocation. Etiology. Teeth injury can occur at any age. Young children learn to walk or fall from chair have maxillary teeth injuries. Children age around 8 to 12 years are more prone to dental accidents. Sports accidents, fights affect teenagers and young children. Incidence of fracture happens 2 to 3 times more in boys than girls. History is very important to be taken before starting any treatment, like when did it happen, to analyze the prognosis of tooth treatment, and where is the fracture of the location, if it is involving teeth only or other supporting structures also. Make sure coagulation disorder if patient has any history. Tetanus coverage is must within the 24 hours of fracture. History of head injury should not be ignored. To check the bone loss, X-ray is needed for proper treatment of fracture. Diagnosis is made from the patient's history. Some tests are needed to be done, like methylene blue stain test, cold stimulation test, light transillumination test, biocclusion test, probing, X-ray, microscope, loops, intraoral camera, and electric pulp test. Clinical analysis is to be done before starting any treatment, like direction of the fracture, is it vertical, oblique, or horizontal? Extent of fracture, is it involving enamel dentine, pulp, or cementum? Mesially, distally, or cervically, apically? Location of the fracture, coronal third, middle third, apical third, or number of the fracture, is it single fracture or multiple fracture? If fracture involves periodontal tissues, probing depth is more than 6 mm. Conservative approach should be preferred. Teeth must be restored first. Deeply stained lines indicate fracture is present. Check with a wooden stick if the mobile pieces are there, should be removed. Symptoms depend on whether the pulp is exposed, the degree of damage to the pulp, the age of the patient, and other factors like tenderness on biting or chewing, swelling, bumps on gums, sensitivity to temperature, lingering pain to cold, spontaneous pain or pain keeping patient up all night, dental history like age of restoration or what treatment was done earlier. Clinical signs. Radiographic features shows separate roots, hairline fracture, halo appearance, swelling on gums, old restoration, probing depth more than 6 mm, sinus tract, furcation involvement, tooth mobility. Next is classification of fracture and its treatment. First is according to WHO in 1994. First is injury to hard tissue and pulp. Second is injury to periodontal tissue. Next is according to Ellis and Davis in 1970. Both classifications are for primary and secondary teeth. According to WHO, injuries to hard dental tissue and pulp. First is enamel infarction N50250. It has small crease lines. These are small fracture lines. There is no chip off and no tenderness to percussion. There is no treatment required, and aesthetically, if required, we can build up and bond the fracture piece. Second is enamel fracture N50250. In this enamel chipped off, but dentin is not affected. Tooth is not mobile and no tender to percussion. Treatment requires only build up and bond the fracture fragment. Third is uncomplicated crown fracture N50251. There is enamel and dentine fractured. There is no mobility, no tender to percussion. Treatment requires calcium hydroxide restoration and build up with composite. And fourth is complicated crown fracture. Enamel, dentine, and pulp is involved. Portion of tooth is lost. May or may not tender to percussion. If tender to percussion, check luxation and root injury. Treatment is root canal treatment. Fifth, uncomplicated crown root fracture, N50254. Fracture line goes below gingival margin involving enamel, dentine, cementum but no pulp. Tooth may or may not be mobile. Tender to percussion is positive. Treatment is stabilize coronal fragment with splint. Sixth, complicated crown root fracture. Enamel, dentine, cementum and pulp is also involved. Tooth is mobile. Tender to percussion is positive and tooth structure is lost. Treatment is stabilize coronal fragment and after 2 weeks root canal treatment done. Seventh is root fracture, N50253. Dentine, cementum and pulp is involved. Tooth may or may not be mobile. There is tender to percussion and there is bleeding from gingival sulcus and coronal fracture is lost. Treatment of the root fracture, like horizontal fracture has better prognosis than vertical, non-displacement has better prognosis than displacement, oblique fracture has better prognosis than transverse. Injury to periodontal tissues. First, concussion, direct blow over the tooth. Tooth is loose, inflammation in mild cases, necrosis of pulp in severe cases. Tender to percussion is positive, tooth is discolored. Treatment, no treatment needed, rest during mastication. To make bite easy, cusp of opposite tooth is reduced. Subluxation, injury to supporting tooth structure, tooth becomes loose but no displacement. There is tender to percussion and bleeding in gingival crevice. Treatment is to adjust the opposite tooth occlusion and splint it for 2 weeks and soft diet recommended. Extrusive subluxation. Tooth is mobile, there is displacement of tooth and it appears elongated. Treatment is push the tooth with finger and splint it for 2 to 4 weeks. Lateral subluxation, there is displacement of tooth palatally or lingually. Fracture of alveolar socket is present. There is tender of percussion, particular metallic sound is present. Treatment is reposition tooth, splint it for 6 to 8 weeks. Soft diet recommended, follow up for 1 year. Intrusive luxation, displacement of tooth into alveolar bone, mobility is absent. On percussion, there is metallic sound. Treatment is reposition tooth, splint it for 2 to 3 weeks and follow up for 1 year. Sixth is avulsion. It is complete displacement of tooth. Tooth comes out of socket. Treatment is reimplantation. Next is according to Ellis and Davis. First is enamel fracture with no dentine. This is a simple fracture of crown involving enamel. The enamel is chipped off. Treatment is not needed. Bond the fragment if needed. Second, extensive fracture of crown involving enamel and dentine but no pulp exposure. Treatment requires restoration or bond the fragment with composite. Third, extensive fracture of crown involving enamel, dentine with pulp. Treatment is if open apex, vital pulp therapy. If closed apex, then RCT. Fourth is non-vital tooth with or without loss of tooth structure. Treatment is remove the fractured segment. There is no pain, no pulp response, tooth becomes discolored. Treatment is if closed apex, then root canal treatment. If open apex, then apexification done. Fifth is avulsion, tooth loss due to trauma. There is loose tooth. Treatment is reimplantation and splint for 4 to 6 weeks. Sixth is fracture of root with or without loss of structure. There is fracture in horizontal direction, oblique or transverse. Treatment is there is no crown fracture but root is fractured, so stabilize the loose segment to adjust the tooth and occlusion reduction is done. Seventh, displacement of tooth without fracture of crown or root. There is no fracture in crown or root, but there is mobility, so tooth is displaced in extrusively, laterally or intrusively. Eighth is fracture of crown, entire crown gets lost. Treatment is root canal treatment and restoration. Ninth is fracture of deciduous tooth, so no treatment is needed. Thank you.